Hey guys, I know you love a good mystery episode, and I have a great case coming to you for this Friday, but I wanted to break it into 2 episodes so that you could have a chance to hear the case without seeing the diagnosis in the title, so that you could Sherlock Holmes it yourself, just like I had to. So, I'd like to share with you the case and not tell you the diagnosis. We're going to call this patient Mr. James, though that was not his name, and then come back this Friday for the big reveal and learn all about the pathophysiology of this condition and how to treat it. Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life. So I get a call from the Progressive Care Unit charge nurse. Her name's Hannah. Hannah is freaking awesome. She knows sick when she sees it. In fact, she can usually predict who on her floor is going to have a rapid response called on their shift. If Hannah is concerned, I am now also concerned. She is a stellar nurse, a stellar leader. I love working with her. Anyways, so Hannah's like, she calls on the phone. Hey, Sarah, I don't know that I can justify calling a rapid response for this patient because his vital signs are technically stable, but his breathing is weird. Can you come look at him? And my answer was, absolutely. So I head to the room, and upon arrival, the patient was laying in the bed, and Hannah said, just watch his breathing. Okay, so I watch as he has several periods of apnea, and his oxygen saturation is dropping, but then he would just start breathing spontaneously, and his oxygen saturation would improve. When I saw the first apneic period, of course, I tried to wake him up to get him to take some more breaths, but he was completely unaffected by my attempts to wake him up. He barely responded, even to noxious stimuli. So I also noted that he felt very warm to touch. My mom hands estimated about 100 degrees Fahrenheit. So not burning up, but just warm and a tad kind of diaphoretic. But my assessment just kept getting weirder and weirder. In trying to get him to respond to me, I noted that he was so stiff. Like, his arms and legs were rigid. I mean, they were movable, so not tonic like a seizure, but oddly stiff. And his pupils were pretty big. I'd say between 4 and 5 millimeters, but equal and slowly reactive bilaterally. So he was tachycardic, like in the 120s, hypertensive in the 190s systolic, but his respiratory rate was all over the place. So many periods of apnea, followed by periods of tachypnea. And I mean, he would go from no chest rise and fall to breathing 50 times a minute. Like, his oxygen saturation was great when he was breathing, but it would dip as low as about 89% when he was having an apneic period. So I ask, what's his baseline? Like, what's he here for? He had just got out from the ER a bit ago. He had come in because his son called 911 for seizures. And when he came to the ER initially, he was talking. Now, he was altered, but talking. But now, I couldn't get him to wake up. Evidently, he was somewhat agitated in the ER. She ended up giving him benzos and started him on dexmedetomidine. When the PCU nurse couldn't awaken him, well, she stopped the dex, and it had been off for about 30 minutes by the time that I arrived. So the dexmedetomidine shouldn't be the reason anymore why he's so out of it. At this point, I'd seen enough. We didn't have a good reason for why he was having these periods of apnea. I mean, he was fairly young. He didn't have the typical build of someone who had sleep apnea. There were just too many other strange things. Like, why is he so stiff? Why are his pupils so large? Why is he not waking up? Why is his blood pressure so high when he's sleeping? Like, what's making him tachycardic? I wanted some more diagnostics to figure out what was going on with this guy. So I called the hospitalist and I'm sharing with him all my concerns. And he's like, yes, these are great questions. Let's just call a rapid response. So at my hospital, initially what I was doing was what we call a nurse consult, where the rapid response nurse just comes and like supports the bedside nurse. So when we call a rapid response, that gets the ICU provider and a respiratory therapist and a phlebotomist to the bedside in addition. Okay, so we called the rapid response, and while I was waiting for the ICU residents and the respiratory therapist to arrive, I started to dig in the chart a little bit more. So it turns out this patient's a known alcoholic. He actually was admitted recently for alcohol withdrawal. He was positive for benzos and cocaine on his drug screen in the ER. His creatinine was 2.4, his sodium 154, his anion gap 22, his ammonia level was only 33, his white count was 22.5, but I couldn't really see a clear source for his infection. Like all of his imaging had come up fine. He had a negative head CT, negative abdomen pelvis. The septic workup was started in the ER. Like they got blood cultures, which are still pending, obviously. His lactate was 1.6. In the ER, he got that 30 cc's per kilogram bolus and broad spectrum antibiotics and a bunch of imaging, and they sent him to the PCU on a dexmedetomidine drip because of his agitation. So here I have a minimally responsive patient with periods of apnea who's super rigid and warm to touch. I describe all of these things to the ICU resident, and he whips out a reflex hammer from his pocket. Now, I thought I was prepared with my fanny pack, but this guy totally showed me up. Sure enough, the patient was hyperreflexive with ankylosing. So we got an ABG. It showed metabolic acidosis. His oxygenation and ventilation were actually fine. I gave him verapamil for his hypertension because of the cocaine in his system. We gave Ativan, and I started a dexmedetomidine drip back up as my shift was ending. So based on our clinical findings and his history, the decision was made to upgrade the patient to the ICU. So here was my note as I ended my shift and handed him off to the oncoming rapid response nurse. Upon arrival at 17:47, patient awake and alert, but not interactive or able to follow commands. Pupils were large, about 4 to 5 millimeters, but reactive bilaterally. Patient mildly diaphoretic and very warm to touch. Vitals as follows: heart rate 120, blood pressure 198/99, SpO2 fluctuating between 89% and 100%, with a perfect pleth depending on the patient's respiratory rate. Rapid response was called for periods of apnea, followed by tachypnea, with respiratory rates in the 50s. SpO2 dropped to 89% while apneic and then came back up without intervention once the patient's spontaneous respirations resumed. Patient very rigid and hyperreflexive. Though not able to follow commands, patient does respond to noxious stimuli, and his gag and cough reflexes are intact. GCS of 9. ABG drawn showing a mild metabolic acidosis. Patient given IV Ativan and verapamil per MD order. See MAR for details. Patient restarted on dexmedetomidine drip at 0.2 mics per kg per minute and titrated to effect. Currently infusing at 0.4 mics per kg per minute, and vitals are as follows. Now, heart rate is 91, blood pressure 143/66, oxygen saturation 93% on 6 liters per nasal cannula, with a fluctuating respiratory rate between 30 and 40. Patient awaiting ICU bed placement, report given to Kevin, night shift, rapid response RN. So, that's it. What do you think was causing all Mr. James' symptoms? Why was he so stiff? Why are his pupils so large? Why is he not waking up? Why is his blood pressure so high? What is making him tachycardic? And what's up with the apnea? So give it a good think, and I'll tell you all about it in episode 114 that releases this Friday.
Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, Nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me, and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.